Okay. Hope that everyone is listening to me. Good evening. My name is Stefano Del Prato. I'm a professor of endocrinology at the University of Pisa. I'm sitting here in my office, which is incredible that I can speak with so many colleagues so far away in India. Here it's a great day. It's been gorgeous. It's sunny. It's a strange winter. That's very unusual for us. But it's a great pleasure for me to welcome you to this webinar. And I'm the next, let's say, 30, 40 minutes, I will try to provide you with some information about the treatment of type 2 diabetes, but more specifically, what the use of the DPP-4 inhibitors, and even more specifically, with what could be the potential for one of the 4 DPP-4 inhibitors, that is linagliptin. Before I move on with the data, these are my conflict of interest. I've been interacting with the industry for many years now. Given my interest in the pathophysiology of type 2 diabetes and the treatment, mostly on the treatment based on the pathophysiological mechanism responsible for chronic hyperglycemia in type 2 diabetes. Now, coming to the treatment of type 2 diabetes, you know that there's been some changes over the time. And the great concept, the most modern concept, at least as proposed by the American Diabetes Association in conjunction with the European Association for the Study of Diabetes, is the need for a better individualization of the treatment. This is because the modern treatment is seen as the efficacious balance between the glucose-lowering power of a treatment together with the safety profile. And as you know very well, because I think that everyone is familiar with this flow chart here, what the ADA and the ASD has been suggesting for the treatment is, first of all, you got to start with metformin, which is considered, at least in this part of the world, as the base and the background for treatment type 2 diabetes. But if you do not get a target soon enough, and in particular if you do not get a target after the first 3 months, you have to move on with the process of treatment intensification. How to intensify, again, is a matter of individualization. And what they suggest that in order to identify the best treatment for the given individuals, a number of items should be considered. I have just, put these items here in the next slides. And the things that we're going to discuss with respect to the DPP-4 and linagliptin in particular is the potential in terms of the efficacy, the effect on the body weight, the risk of hypoglycemia, the treatment adherence, and of course, the safety. Now, let me go back just for one moment in order to discuss with you the efficacy. What is the ADA-ASD again recommending? Metformin first, and then on the same line, a number of potential treatments. All of them are there. The sulfonylurea, the TZDs, the DPP-4, the recently introduced SGLT2 inhibitors, the GLP-1 receptor agonist, and of course, even insulin. Now, what is interesting here, that in terms of efficacy, some of these treatments here are considered to be quite powerful. When you come to the DPP-4 as a choice after metformin, what these people are suggesting is that, yes, the treatment is something which is available. However, in terms of the efficacy, they claim the efficacy is a sort of intermediate. And I really like to a little bit of a challenge this concept here of intermediate. Let me just use a meta-analysis. This meta-analysis has been recently published by McIntosh, and what has been done here was just to look at what is the average reduction in A1C that you can achieve in people failing to metformin. So this is the second step. And now what you can see here, this is the zero line, and this is the decline in A1C. Now you can discuss whether there is anything that is more powerful. Yes, maybe insulin is a little bit more powerful here, but you can see also that the confidence of interval are very much overlapping one to the other. And if you just come up with a sort of average reduction in the A1C that you can achieve, when you add an agent on top of metformin, you can come up with something which is not very much different from the other ones. So in terms of efficacy, I don't really see any major difference in terms of reduction in A1C. It looks like that this reduction in A1C is sort of fluctuating around the mean as indicated in the slide here. Now, rather than talking about efficacy per se, maybe what is even more important is to see how durable is the efficacious effect of a treatment. Now, remember that most of these trials here that has generated this meta-analysis are trials lasting 6 months or something like that. So 6 months in the lifespan of a diabetic individual is just a very small part of it. It's a drop in a sea, if you want. So what we like to have in terms of a treatment is a durable treatment. Now, when you come to sulfonylurea that are considered, for instance, very commonly used, more powerful than, for instance, the DPP-4, now there's a number of trials, and it's just in a conservative list of those, showing that indeed the sulfonylurea can cause a significant improvement in terms of A1C levels. However, after this initial rapid improvement in glycemic control, all of them have been associated with a progressive loss of action of the sulfonylureas. In other words, the durability of the effect of the sulfonylurea is not that strong. And this has been clearly demonstrated in the ADOPT study that you must be very aware of. Now, in the ADOPT, what has been done in people with newly diagnosed diabetes was to randomize them to sulfonylurea, glyburide or glibenclamide, to metformin and rosiglitazone, a TZD. And what it turned out that out of the three, the worst performance was the one of the glibenclamide. So more people over the time were failing to monotherapy with glyburide, with less people failing with rosiglitazone, and intermediate response was obtained with metformin. What do we have for DPP-4 and in particular for linagliptin? Now, this is a study that we have published a few years ago, looking at the effect of monotherapy in type 2 diabetic individuals. Now, what you can see here is this usual 0.8, around 1% reduction in A1C in these individuals with an average A1C to start with in the range of 8%, so a typical type 2 diabetic individual. And what you can also appreciate here, that's over these 2 years of the follow-up, there was very little change in the A1C once the A1C has reached its nadir. And what you can also calculate is that the overall change was less than 0.14%, suggesting that there was no increase after the initial 24 weeks in A1C for the ensuing period till the end of the observation. Now, these are individuals with, let's say, the typical 8% or A1C to start with. But what's turned out is that the DPP-4 and linagliptin in particular can be quite effective even in people with much worse glycemic control to start with. Now, what you can see here is the two cohorts. These are two different analyses of the cohorts of these individuals here. This is the protocol completer cohort. This is the full analysis set. And what you can see here is the effect in terms of reduction in A1C when you use a combination of linagliptin and metformin, or you just use the linagliptin alone. And sorry, this is a mistake. It's not metformin, that is just linagliptin itself as a monotherapy. Now, two things that I really like to draw your attention on. First of all, that in people with an A1C to start with around 9.7%, even the monotherapy with linagliptin is associated with an incredible 2% reduction in A1C, which of course is much greater when you have the combination of linagliptin and metformin. But yet, please consider this reduction in A1C with the monotherapy in these poorly controlled diabetic individuals. So the difference is a significant one, but still, this is a 2% reduction as opposed to something close to 3%. Now, this is the absolute difference. It may be of interest to look at what is the time course of the change in A1C. And what you can appreciate here once again is this progressive decline in A1C, progressive improvement in glycemic control that was not that bad with the linagliptin as a monotherapy, but of course it was much better with the linagliptin plus metformin. And what is also important to try to identify is, in this initial part of the treatment, it's also important to notify, to try to understand, is how many people over the 2 years of treatment can we bring down to a target A1C of 7%, as it has been represented here. And actually what it shows you is that in just 24 weeks, it's possible to achieve normal glycemia or target A1C represented by an A1C lower than 7% in almost 60% of the people when you use the combination, but yet you can have down to the target 40% of the people even just with the monotherapy with the linagliptin. All this is associated with a very nice safety profile. As shown here, just reporting the most common adverse events, and what you can also focus your attention on is the effect on the pancreatic and the pancreatitis and other conditions here. So what you can see, there is not very much of a difference. If there is a difference, maybe is down here with hyperglycemia, that of course tend to be more common with the monotherapy as compared to the combination treatment. So two information here, which I think it's worth to consider, maybe we can discuss later on. The first one is that the DPP-4 can be effective in people with a poorly glycemic control to start with, but of course, the combination of linagliptin with metformin is even more impressive, which brings us to consider that the rationale of combining metformin with the DPP-4 inhibitor. Metformin is a very well-known drug. It has been considered for a long time an insulin sensitizer. What we have been appreciating over the time that metformin exerts a specific effect on the hepatic glucose production, mainly through inhibition of gluconeogenesis. But metformin, to some extent, may also improve, although there is much more debate on this, peripheral glucose disposal, particularly in response to insulin stimulation. And metformin has been recently highlighted, may also have a direct effect on glucose utilization in the gut. Now, this is the classical view of the action of metformin. Now, it turns out that metformin has other interesting therapeutical features that we want to consider. And in fact, metformin, that was considered as sort of a sensitizer, now turned out to be actually an enhancer of the GLP-1 effect through several mechanisms. First of all, metformin can increase the expression of the GLP-1 gene, so more GLP-1 can be synthesized at the level of the L cells, so more GLP-1 will be made available. Moreover, that GLP-1 will exert a better action on the pancreatic islets because it has been shown to exert a sensitizing effect, particularly at the level of the beta cell, without not having much of an effect on the K cell producing GIP. Now, if you have more GLP-1 that can be produced, and this GLP-1 have a better chance to sensitize the beta cell, and now on top of this, you also have a DPP-4 inhibitors. Now, this increased availability of GLP-1 may exert a much greater effect in terms of the regulation of the beta cell function. And this picture here actually turned out to be quite of interest if you do consider more recent information that has been gathered, showing that within the islet, within the human islets, GLP-1 is actually expressed. Now, this is the staining for the GLP-1, and here you can see the staining, the staining for glucagon. Here is the staining for the GLP-1, and you have the merging. And what it shows you is that the GLP-1 is indeed present in human islets and is mainly expressed at the level of the alpha cell, which makes a lot of sense because both GLP-1 and glucagon are derived by a common precursor known as glycemtin. And it's really the effect of specific converting enzymes, more specifically PC1, proconvertase 1,3 enzymes that chop down the glycemtin to GLP-1, or the proconvertase 2, which is responsible for the synthesis out of glycemtin of glucagon. So the two moieties can be expressed in the same cells. And actually what it turned out in these experiments that we are performing in our lab, that these reciprocal changes may be modulated by a number of conditions, and some of them are clinical metabolically relevant condition, like the condition represented by hyperglycemia or by high concentration of free fatty acid or by the presence of interleukins. So what you can appreciate here is for any stimulation of the GLP-1, you have a concomitant reduction in the glucagon, or vice versa. For any reduction in the glucagon cell release from these culture cells, you have an increase in the GLP-1 production. Now, this story, although it is very preliminary, is quite of interest for a very simple reason. because GLP-1 can then be produced by the alpha cell. That GLP-1 will spill over within the islet. But that GLP-1, as occurs in other conditions, in other organs, in other part of the body, will be immediately cleaved down by the effect of the DPP-4. And in fact, there are demonstrations that the D-peptidase 4 enzyme is expressed at the level of the alpha cell. So in other words, the alpha cell can be a producer and modulator of the amount of the GLP-1 that can be reversed into the beta cell. Now, if you assume that now you can inhibit the activity of DPP-4, you can also hypothesize that more GLP-1 will be made directly available to contact beta cell. And that may be one potential explanation for the preclinical data suggesting a protective effect of the linagliptin on the human pancreatic islet survival. Here you see the experiments in green. These are, in gray. These are the control islets exposed to vehicle. In brown, you can see the effect of the linagliptin when it's added into the medium in response to changes in glucose concentration in the medium. So the effect of the hyperglycemia, of palmitate, lipotoxicity, interleukin, inflammation, or oxidative stress, as indicated here by the oxygen peroxide, on apoptosis of these pancreatic islets. And what you can see here very clearly is that the apoptosis is very much reduced in response to hyperglycemia, to glucotoxicity, to inflammation, to oxidative stress when linagliptin is on board. Of course, these are preclinical data. Of course, these are in vitro data, and we are wondering whether this protective effect also is accepted in vivo. This is not an easy question to answer. We can only look at what happens in response to the treatment with linagliptin, as we have done here with monotherapy in type 2 diabetic individuals, in some proxy for beta cell function in vivo, as indicated here in terms of the change in the insulin per insulin ratio, in terms of the OMA-B, in terms of the ratio between the area under the curve of insulin and the area under the curve of an oral glucose stimulation of glucose. And what you can appreciate that all these indexes here are indeed improved by the effect of the treatment of linagliptin. Can be this taken as a proof for the protection of the beta cell function in humans with DPP-4 and in particular with linagliptin. Now this, as you can imagine, is an interesting, challenging, stimulating hypothesis. The question is, how can we verify it? Now, I just use the word verify because actually a trial is out there which is called Verify. And the Verify trial is exactly asking what is the efficacy of early combination of metformin and a DPP-4 inhibitor, in this specific case vildagliptin, in type 2 diabetic individuals when they are recruited in the early stage of their disease and when they have a very mild hyperglycemia to start with, as indicated by the recruiting A1C range, which has to be within 6.5 and 7.5. But what is of interest here is that in order to prove a potential protection of the beta cell, you need to prove durability, and the study has been planned per protocol to last 5 years. And during this study, there will be a count of the people that are going to lose control, and of course, we will try to link that result, the clinical results, with some estimation of the beta cell function. Now, the efficacy is important, but the efficacy of linagliptin is there for people in monotherapy with a mild hyperglycemia as well as with poor glycemic control, as indicated earlier. What it turns out to be interesting is that the linagliptin and DPP-4 can be effective also in the advanced condition, in the advanced stage of the disease. For instance, if people are really requiring insulin, as is shown here in this slide, but this time it has been published on Diabetes Care a couple of years ago. Now, what you can see here is that type 2 diabetic individuals on basal insulin regimen, and some of them have been added and randomized to treatment with a placebo. Another group has been randomized to treatment with a 5 milligram a day of linagliptin. And what you can see here in this initial phase, when the insulin dose was kept stable, in other words, these people were not titrated in terms of the insulin dose, you can see this nice improvement. The question is this because of the linagliptin, or is because these people here could not be properly titrated? So what is interesting about the studies is that after the initial 24 weeks of treatment, the people were continued in the trial. However, those that were on insulin and placebo were then allowed to have been titrated to try to achieve better glycemic control. And what you can see here is the titration is indeed associated with an improvement with respect to the initial 24 weeks. Yet, this improvement is not sufficient to abolish the major improvement that has been achieved with the addition of linagliptin on top of basal insulin. And even more interesting, this result here in thermoglycemic control have been achieved with a not significant increase in the risk of hypoglycemia, and with actually a trend for a better response in terms of the body weight. Although this was not significant, it remained lower with the linagliptin, and they still tended to go up a little bit with the intensification of insulin. So let's say overall no major change on body weight, no major change in the risk of hypoglycemia, but adding linagliptin on top of basal insulin was associated with a significant reduction in A1C, in other words, better glycemic control. So I think that efficacy is there. So if you go back to the ADA is the flowchart, I would like to claim that the efficacy is at least comparable to the other treatments here, but even more that the DPP-4 can be effectively used either in monotherapy, but even better in combination with metformin because it makes a rational combination, but also it can be also used in the more advanced stage of the disease, as for instance in triple therapy or on top of people already treated with insulin. Now, so efficacy is there. What other items do we need to discuss? Of course, the effect on the body weight. And again, we know that the treatment in type 2 diabetes may have quite an impact on body weight, with drugs that may be almost all the time associated with an increase in body weight, as typically occurs with insulin treatment, but also with sulfonylurea, with glinides, and of course with TZDs. And with some, particularly the GLP-1 receptor agonists and the acarbose, that may be associated with a reduction in the body weight, and with the DPP-4 exerting a neutral effect. This is an example of the neutrality on the body weight effect of linagliptin, that look at the changes in body weight in all the different conditions where linagliptin has been looked at, in monotherapy, up to the addition to insulin. And what you can see here, first of all, modest changes, but in other words, a fluctuation around the mean with very minor effect in terms of the body weight. Although it may be of interest that when you use the DPP-4 and linagliptin as compared, for instance, to a sulfonylurea, you may end up with some difference there that may be turned out over the time of quite of interest. Now you can see here the typical increase in the body weight in people added of glimepiride on top of metformin, as compared to people where linagliptin was added on top of metformin, with an average difference of the two of about 3 kilos. So there might be something there that could be also of interest in terms of the body weight. The major concern in treatment of type 2 diabetes is the risk of hypoglycemia. And I personally believe that the risk of hypoglycemia is still not yet fully appreciated, because hypoglycemia is an event, of course, but this is an event that can be associated with a multitude of adverse events, as this depicted here. Let me just remind you that hypoglycemia, particularly in vulnerable people, may be a trigger for cardiovascular complication. That hypoglycemia may be a reason for poor quality of life. That hypoglycemia may interfere with adherence. That hypoglycemia may impair or may impact on the cognitive function of these type of diabetic individuals. So let me just give you an element for the how common is hypoglycemia in type 2 diabetes. Here in Pisa, in my hospital, I had one of the postdoc fellow to go to the emergency room and collect all admission to the emergency room in the past 5 years of people with hypoglycemia. And we have then identified those with type 2 diabetes, and this is the treatment, the anti-diabetes treatment that was associated in these people reporting to the emergency room because of severe hypoglycemia. And of course, as you can expect, at least half of it is because of insulin. But yet, this 42% of people with severe hypoglycemia requiring access to the emergency room is not that far away from the 38% of people on oral agent. Which oral agents? And you can see here which oral agents are responsible for this hypoglycemia. Now, when you look, secretagogues, sulfonylureas, either in monotherapy or in combination, accounts for up to 92% of these 38% hypoglycemic episodes requiring hospitalization or emergency room. And we could only identify 8% that have been associated with metformin or DPP-4 inhibitors. Actually, it's interesting because this is a 1 to 10 ratio. Keep that in mind, because when you compare, for instance, the ratio between hypoglycemia observed in the trial when glimepiride was added on top of metformin in type 2 diabetic individuals, it's not that different in terms of the ratio with the one that's been observed with linagliptin. Once again, this is very close to 1 to 10. So there is more hypoglycemia, or if you want much less hypoglycemia with linagliptin, and also you can count how many of these people had just had one episode or two episodes or more episodes and so on and so on. But each one of these category was much, much lower when linagliptin was on board as compared to glimepiride. Now, low body weight effect, neutral body effect on the body weight, lower risk of hypoglycemia. One way that is very common to express now these results is just to look how many patients are then able to achieve the target A1C without experiencing hypoglycemia and exhibiting no weight gain. And what you can see here again is the improvement in the glycemic control, is the change in the body weight I already showed you, and the ratio in terms of the hypoglycemia. Now, if you count how many of them has achieved this 7%, how many have achieved that without increasing the body weight and with no hypoglycemia, now you can easily appreciate how this is much less frequent in people treated with linagliptin as compared to glimepiride. Almost less than 50% of these people, 50% of people had achieving the effect with linagliptin. So linagliptin can really provide with a more comprehensive control in terms of glycemic control, body weight, and reduced risk of hypoglycemia. Now, and I think that this is interesting and important because at the end of the day, when you evaluate a treatment, what you do is really to weight off the efficacy, the reduction in A1C, as opposed to adverse events. For instance, the increase in the body weight and increase in the hypoglycemia. So if you have a treatment that is associated with a less effects, side effects, you can consider that for the same degree of efficacy as compared to others, you have a relative better efficacy. And if you have a better relative efficacy because you have less side effects, you may also speculate that this better efficacy may translate into better adherence because you have better glycemic control without less side effects. And adherence is a key thing in terms of the treatment with type 2 diabetes, because there are data suggesting that there is a direct relationship between adherence and achieved glycemic control. Here, what you can appreciate is the percentage in terms of adherence as compared to the A1C reduction. And you can easily calculate that for each 10% increase in adherence, there is an added value in terms of minus 0.15% reduction in glycated hemoglobin. Let me translate into a different way, in different words. We may have the best therapeutic option, but if that drug is not taken, there is no efficacy at all. So we need also to consider adherence because adherence is very important. Now, adherence also brings us to consider the issue of the safety. And safety, of course, in judging a treatment is very important. Now, it is very important, particularly in type 2 diabetes, because the vast majority of the type 2 diabetes population, at least in my country, is represented by elderly people. And elderly people tend to be more frail, more vulnerable. So we want really to have a safe treatment. Now, it turns out that DPP-4 tend to be very helpful in treating elderly individuals. What you can see here is the response in terms of A1C reduction of linagliptin in different categories of age. And what you can appreciate that, first of all, there is no major difference. So linagliptin works in young people as well as in elderly, with some suggestion that maybe in the elderly it's a little bit even more effective than it is in younger people. Now, this is very important because, as I mentioned, elderly people tend to be more vulnerable, and they tend to be more vulnerable because they tend to have more commonly associated other comorbidities. Here you can see, for instance, that this study that's been published a couple of years ago on Lancet, looking at the population of aged type 2 diabetic individuals, and what you can see here, that a large percentage of these individuals either had a long duration of the disease, or comorbidities, or medication burden as indicated by the number of drugs they have to take. So what you can get when you use a DPP-4 like linagliptin in a population with this degree of vulnerability. What you can achieve is a nice glycemic control with a significant, mild or significant reduction in A1C without exposing the population to an increased risk of hypoglycemia. Actually, this issue of the hypoglycemia in these elderly individuals has been very recently revised in this paper that has been just published on the EOM. And what you can see here is the Kaplan-Meier curve for the overall hypoglycemia as well as confirmed hypoglycemia in elderly people on linagliptin as compared to other treatments. And what you can appreciate here is that the number of hypoglycemia, the risk of hypoglycemia, the development of hypoglycemia is always lower in people on linagliptin as compared to the other treatments. And of course, what is important here is to consider the major role in terms of the risk displayed by sulfonylurea. But what you can see here, once again, is that this reduced risk of hypoglycemia is not really affected by the presence of the absence of sulfonylurea. So in absolute terms, you may have more hypoglycemia when the sulfonylurea is on board, but yet the presence of the DPP-4 inhibition seems to suggest a better protection in terms of the risk of hypoglycemia. Now, in the elderly population, there are other issues that you want to consider, and one thing is the kidney function. Now, in this elderly population that I have just shown to you, over the 24 weeks of treatment, there was no change in terms of GFR. So the linagliptin didn't really alter what was the natural history of the change in the GFR of these elderly individuals here. And I think, again, this is very important because the GFR tend to be lower to start with and tend to decrease at a greater rate in elderly individuals. And most of the elderly individuals do have significant impairment in the renal function, as indicated in this Italian cohort, including something like a total of something like 15,000 diabetic individuals. So we want to be very safe with respect to these subjects here. And linagliptin is easy to be used and apparently is safe because, as you know very well, linagliptin does not require any dose adjustment as a function of changes in the kidney function. So even in people with very low GFR, we can continue with the typical 5 milligram dose of linagliptin. Of course, all the other DPP-4 inhibitors can be used. However, they require over the time adjustment in the dose. So that will require people to come back, have a monitoring of their GFR, and then in case to adjust the dose of this DPP-4. Now, as I mentioned, it's not only that it can be used simply, but it can also be very effective, because when you look at people with a very high risk for renal and cardiovascular disease, at 18 weeks, 24 weeks, you can see how the use of linagliptin is associated with a significant reduction in A1C as compared to placebo. But even more, in these people with high risk for renal and cardiovascular disease, this can be obtained with a very better safety profile as indicated here. Now you can see here that there is no major signal. Of course, the only signal that you can appreciate is the increased hypoglycemia, which is mainly driven by the concomitant use of sulfonylurea. You can see here the hypoglycemic events in people that were on sulfonylurea as a background as compared with those without sulfonylurea. And even in these individuals, the absolute rate of severe hypoglycemia is very low. So in people with a high risk for renal dysfunction and cardiovascular disease, the use of DPP-4 linagliptin seems to be pretty safe. Even more, in people with progressive decline in GFR, linagliptin retain its efficacy. You can see here 3 different categories in terms of GFR: normal, mild impairment, moderate impairment, and you can see that the reduction in A1C is very similar across the 3 groups and still significant as compared to the placebo. But even more interesting, not only there is no effect and possibility to use the linagliptin. The linagliptin in a pool analysis suggested to be associated with a significant reduction in microalbuminuria. This reduction was accounted for by a 29% reduction as compared to the comparators. Now, this result here has been successfully confirmed, and this reduction in microalbuminuria in people treated with the linagliptin turned out to be irrespective of the ethnicity, white or Asian, irrespective of the starting glycemic control, irrespective of the starting blood pressure control. And even more, the effect of the linagliptin in microalbuminuria is irrespective of the change in glycemic control throughout the study. In fact, what is represented here is the reduction in microalbuminuria, and what you can appreciate, there is no difference in people with no change in A1C as well as in people with the largest drop in A1C. Now, maybe that the linagliptin is affecting blood pressure that we know is a very powerful risk factor for microalbuminuria. Yet, this does not seem to be the case, because when you compare people with an increase in systolic blood pressure, or people with a decrease in systolic blood pressure, or people with a stable systolic blood pressure, again, there is no significant difference in terms of reduction in A1C. And this obviously has prompted a number of studies, still ongoing, to try to understand how much of this effect is mediated through DPP-4 inhibition per se at the level of the kidney, and how much is really secondary to improvement. Safety also has to do with a significant heart endpoints. Cancer, pancreatitis, cardiovascular events is the one that's been considered for the use of the DPP-4. And this is a meta-analysis looking at all the randomized clinical trials that have been available at the time of the publication of this paper here. And what it shows clearly, there is no major signal in terms of the cancer, no signal in terms of the pancreatitis. If there is a signal, that signal is associated with a reduction in the risk of the MACE, the cardiovascular events. But you know very well the meta-analysis cannot answer the question. What we need to have is cardiovascular intervention trials. Now, as far as linagliptin is concerned, when the clinical development trials have been considered, and the effect of linagliptin has been compared to the comparator, what it turned out to be is that linagliptin was associated in this post-hoc analysis, with all the limitations of the post-hoc analysis, in a significant reduction in the risk of cardiovascular, on the number of cardiovascular events. Even more, however, what we need to do to have, however, is result, as I mentioned, of intervention trials. I don't need to remind you that we already have responses and results from SAVOR, EXAMINE, TICOS, and I think that I don't need to tell to you that these 3 trials have been provided safety for the treatment without no significant reduction in the cardiovascular risk. Linagliptin also has been evaluated in cardiovascular outcome trial. But there is a difference here. Of course, there is linagliptin trial comparing linagliptin to placebo, safety. But it's also an interesting study that is comparing, and it's the only study available, the linagliptin effect on cardiovascular events for a superiority as compared to glimepiride. So these data are going to be released in the next future, and I think this will be quite an interesting information that we can get because of the potential of using safer drugs as compared to the sulfonylurea, particularly in terms of cardiovascular events. The other issue already mentioned is the cancer of pancreatitis. Let me just remind to you that both the FDA and the EMA, in a conjunct statement, they come up saying that at the time being, there is no way to really solve out whether the DPP-4 and the incretins are indeed associated with an increased risk of cardiovascular, of pancreatitis or cancer. So from this point of view, I think that we can remain quite satisfied. So let me try to wrap up, because what I was discussing with you is what is the opportunity of treating type 2 diabetes with a DPP-4 inhibitor in terms of their efficacy, on effect on the body weight, risk of hypoglycemia, treatment adherence, and safety. And what I have tried to do with you is actually to discuss what is the potential for linagliptin in the treatment of type 2 diabetes. And these are my conclusion for the sake of the discussion. Efficacy, I think that I tried to explain to you and to demonstrate to you that the efficacy is at least as good when added on top of metformin as the other second-line treatment. Of course, what we would like to know is to have even better and stronger evidence in terms of the durability, although some potential signals are there for durability. And also what we need to understand is whether and to which extent this durability may be because of a potential protective effect on the beta cell function. But this, again, has to be determined. As far as the body weight gain is concerned, I think that, all of us agree that DPP-4 have a neutral effect, and maybe also providing a little bit of an advantage, particularly when directly compared to sulfonylurea. Hypoglycemia, the risk is very low. Remember, I showed you data on the use of the linagliptin on top of insulin treatment. So that is the worst condition in terms of risk of hypoglycemia, and yet there was no worsening for hypoglycemia. So DPP-4 are not associated with a very trivial effect on the risk of hypoglycemia. And because of this effect on the body weight, and because of this very low risk in terms of hypoglycemia, treatment adherence may become an advantage with DPP-4, particularly when used early on in the treatment. People may stay in the treatment for longer because they are satisfied with the reduction in the glucose levels, and not really very much concerned about the risk of hypoglycemia and body weight. Safety, we have data for the DPP-4. They're supposed to be safe. However, I think that the linagliptin has the potential advantage of a cardiovascular outcome trial with a predefined comparator, and that may shed more light on the potential risk and potential advantage of using DPP-4, in particular linagliptin, with respect to cardiovascular protection. Although linagliptin also has another trial that is going to address specifically the safety. So we'll have more information in the future. With all this, I think that we may have now another opportunity. It's just up to us to try to select the right individual for this specific intervention. And with that, I will stop here, and I will be more than happy to try to answer any question or comment or receive any criticism you may have with what is my view with respect to the DPP-4 and in particular for the linagliptin. And I can see here already a number of questions. So let me see if we can move on and try to answer some of these questions. Okay, one question is about clarifying the pharmacological action of this gliptin. Now, linagliptin is a very specific inhibitor of DPP-4, and through this effective and constant inhibition, so it allows us to be taken once a day because it has a long effect, and because of the inhibition of DPP-4, as it does for the other DPP-4 inhibitors, there is more availability in terms of the GLP-1 that makes this pharmacological action. Although I have to say that for linagliptin as well as for other DPP-4 inhibitors, whether what we see in terms of the pharmacological action is totally due or is completely due to increase availability of GLP-1 remain to be defined, remain to be understood. There are other suggestions that maybe local DPP-4 inhibition, particularly at the level of the portal vein, may also contribute in regulating some of the hepatic glucose metabolism, then add on the top of the effect of the GLP-1 per se. Now, the other question is if I'm satisfied with the long-term safety profile of teneligliptin vis-a-vis linagliptin. I have to confess I have not much information and experience with teneligliptin, much more with linagliptin. Linagliptin is widely used as far as it can be used in my country and in Europe, and I think that what is very much appreciated in terms of the linagliptin on top of the long-term safety is also the easy use, particularly the not requirement for really considering a risk associated to impairment in the kidney function. So the fact that linagliptin can be used in any people, so without very much paying much attention into the GFR. Of course, we need to pay attention to the GFR for other reasons, but not for dose adjustment. Now, someone is asking me about linagliptin and NAFLD diabetic patients. I'm not aware of specific study using linagliptin on NAFLD. There are some trials looking at DPP-4 and NAFLD. I think, however, they know that there may be an effect there, but most of the effect is not clear if it can be accepted directly at the level of the liver, or much of the effect that we may be able to see, it's because of the overall improvement in the metabolic control. Dr. Shah is asking me how safe in renal and cardiac patients. I thank you very much for this question, but I think that I mentioned to you results in people at a very high risk for renal dysfunction, renal disease, and cardiovascular disease. And as far as we can see from those data, from those trials, in these individuals, in spite of this increased risk and high risk for renal and cardiovascular events, linagliptin will turn out to be pretty safe without very much of the change in the safety profile. The only thing that I pointed out to you is maybe some differential response in terms of the hypoglycemia, but that's not because of the linagliptin, but it's because of the background cardiovascular background use of sulfonylurea. Dr. Bennett from Chennai is asking me if we can use linagliptin in young adults as well in elderly diabetic patients without dose adjustment. Definitely yes, because as I try to provide you with some information, first of all, linagliptin provides us with the same efficacy irrespective of the kidney function. Provides the same response irrespective of the age, and is not associated with any worsening in the kidney function, and naturally it may result in some improvement in terms of the microbillinuria. How much that reduction in microbillinuria can provide an advantage in a more specific manner still remains to be questioned and to be demonstrated. But my suggestion is yet, at the time being, there is no contraindication or concern on using linagliptin in young as well as in elderly diabetic patients. So I think that linagliptin actually is a good treatment for elderly diabetic individuals. Dr. Narwadi, and forgive me if my pronunciation maybe is not the correct one, is asking me chances of hypoglycemia. Yes, there are chances of hypoglycemia. But most of these chances, there is always some chances. Remember, for instance, in the UK-PDS, in the metformin group, there was a 5% overall number of patients with hypoglycemia. And metformin is considered pretty safe with that. But the hypoglycemia that we may be seeing with the use of DPP-4 and the use of linagliptin is not because of DPP-4, but rather because of the background therapy. Any therapy that may provide you with an increase in hypoglycemia will remain there. So DPP-4 linagliptin is not abolishing that, but it's not increasing. Remember the data I showed you on people treated with basal insulin. Insulin is probably the largest and the most common cause for hypoglycemia. Yet, adding linagliptin on top of insulin treatment was associated with a 0.7% reduction in A1C with no signal for increased risk of hypoglycemia. So from this point of view, I think that DPP-4 and linagliptin is pretty safe. Again, Dr. Singh is asking about kidney failure. I think that we already covered this in the presentation as well as in responding prior questions. So there is no problem using linagliptin, and linagliptin does not require to be adjusted in dose for even people with a very low GFR. And there are recent data showing efficacy of the use of linagliptin and safety in people on dialysis. Just a very recent paper published that really goes along with other data of the same kind for other DPP-4 inhibitors. Now, Dr. Mirdul Bera can it be a better gliptin in post-AMI patients? Now, I don't know what you mean for better. If you think about safety, first of all, for linagliptin, we need to wait for the cardiovascular outcome trial. And as I said, we have two trials. The first one is Carolina, and this is a placebo-controlled trial, very much alike what the Food and Drug Administration of the United States is requiring to show sulfonylurea. So very much as a trial very similar to SAVOR, Examine, and TICOS. So where equipoise treatment has been used to try to prove safety, and safety was proven for the other ones. So we need to see the results of the trial for linagliptin. If the linagliptin turn out to be safe as much as at least sitagliptin, TICOS, and allogliptin, Examine, and not associated, as has been reported with the SAVOR, with an increased risk for hospitalization for heart failure, I think that linagliptin would be another option in our hands. However, because of Carmelina, which is the cardiovascular outcome trial, that is comparing directly the use of a sulfonylurea as well as, and on the other hand, the use of linagliptin, that may provide us with a superiority results, may also provide us with a better information on how to treat patients with a prior myocardial infarction. Again, I think it's difficult to answer the question of Dr. Bera for a very simple reason. We have no head-to-head comparison. So we cannot just, come to any final conclusion saying this is better, this is not better, because there is not head-to-head comparison. And this is the only tool we have to come to this conclusion. What I can say, as I showed to you, is that the linagliptin can be used in all stages of chronic kidney disease, even in people on hemodialysis without any significant improvement and without the need of changing the dose. The linagliptin is excreted in the stool through hepatic excretion, although there are data suggesting that even in the presence of a liver disease, the use of linagliptin is safe. So that the system is sufficient to dispose of linagliptin even in people with impaired liver function. What else we have here? I think that the gliptin acting in a glucose-dependent manner, but how this works is essential because, as far as I understand, drugs are like bullets. Once it is going to kill the target. It also showed in your slide that when used with sulfonylurea, it increased hypoincidence in. All right, okay. Now all right. This is a very good and interesting question, the one from Dr. Agarwal. First of all, let me reiterate what I tried to convey to you. Of course, the DPP-4 inhibitors, the linagliptin, is not going to abolish hypoglycemia as triggered by sulfonylureas or insulin. That is independent of DPP-4. However, what it turns out to be is that the linagliptin is not interfering, the DPP-4 are not interfering with the counter-regulatory hormones. And actually, if any, there are data from Dr. Arén from Sweden suggesting that the sensitivity of the alpha cell is to some extent improved in response to a drop in glucose. So the 19% you're referring to hypoglycemia is not because of the linagliptin, it's because of the sulfonylurea. So the suggestion is, if sulfonylurea is not needed, if sulfonylurea can be avoided, which also implies a lot of consideration, including the cost effect, but if that is possible, I would try to avoid the sulfonylurea and start off as soon as possible with the DPP-4, because for the same token, for the same reason, that it is associated with glucose efficacy. It is associated with low risk when used on top of metformin, when used on top of glitazones, when used on very recent data on top of GLP-1 inhibitors. There is no actually increase at all in the risk of hypoglycemia. Because the DPP-4 linagliptin is not associated with the body weight, all these conditions here may translate into better adherence and maybe also help in terms of the durability. So I hope that I have been clear with that. Now, the second question I have from Dr. Agrawal is, gliptins are meal-free meals, can be given any time, but in your view, what is the best time for gliptin, and if there is any difference among gliptins with regard to time administration? The only difference in terms of the time administration is when you compare linagliptin, for instance, and other DPP-4 versus vildagliptin, because vildagliptin, if it is used in combination, if it is used in monotherapy, has to be administered twice a day, while linagliptin is a QD, so once a day. Having said so, at least in all the experience we have in this part of the world, there is a much, much larger use of fixed combination of metformin and DPP-4, and that will translate into twice a day administration. But if you have to administer the gliptins by per se, I think that the best time is the one that reduces the opportunity for people forgetting to take their pill. So try to discuss it with your patient and try to increase as much as possible adherence, and to increase as much as possible taking the pill one day after the other. I think this is key, more than discussing if lunchtime, dinner time, breakfast time is better and so on. If breakfast is the time when people are much less to forget to take the pill, go for that. If that is evening, go for that. So I think that is my suggestion. Now, one question is, where did the gliptin get metabolized? As I already mentioned, is most likely at the level of the liver. Although, as I already mentioned, there is not very much data suggesting that in the presence of impaired liver function, there is a contraindication for the use of linagliptin. And then because of this metabolism, the linagliptin can be used in people with impaired kidney function. More questions coming, and the next question is how linagliptin better than others. So again, let me tell you, it's difficult to say because we would love to have head-to-head comparison, but that's not the case. I think there is one potential advantage here, though. First of all, that the drug doesn't need any adjustment for impaired kidney function. So you can start with your linagliptin in a person with a GFR of 60, and you don't really need to take much attention if the GFR is progressively dropping. You have to pay attention for the drop of the GFR, but not because of the linagliptin, because you have to adjust, but because of what it means, clinically speaking, for a reduction of the GFR. So I think that is one key thing. Moreover, I think that linagliptin has provided quite a wide range of use in a number of people, in monotherapy, in combination, in young people, in elderly people, in fragile, vulnerable people, and so on and so forth. And I think that this provides, sufficient confidence for the use of linagliptin. But again, as I said, I think that the kidney and the ease of use in people with kidney impairment make linagliptin an attractive and interesting therapeutic approach in type 2 diabetic individuals. I don't see any further question, and I don't know if that means that I made everyone fed up with my elucubration. But if there is no more further question, I really like to thank you very much for spending this time with me. But in the meantime, we got another slide. Why hypoglycemia not occur? But I don't understand what it means. Okay. So again, as I was saying, I'd really like to thank you very much for spending this time with me. It's I let me tell you, it's also a strange feeling because when you have to interact with people, of course, it's different. But however, this is a fantastic way. And if there is any further question that come to your mind, you can write to me. My email address is easy. It's stefano.delprato@med.unipi.it. And I'll try to answer your question. And if you have any comment or any suggestion, please, I would really like very much to receive them. Thank you very much.